Another session on building awareness around cancer and specifically around acute lymphoblastic leukemia today. This is part of a series we've been doing, and today we will discuss navigating treatment options for acute lymphoblastic leukemia. Our message continues that we need to take action quickly and care should not wait. We are very privileged to have with us two experts. We've got Dr. Natraj and Dr. Kishore Kumar. I will introduce them in just a minute. Quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and their caregivers to share personal experiences, information, and learn from each other as well as healthcare professionals. And the whole idea is the better informed you are, the more engaged you are in managing your condition, the better choices you will make, and you will feel more empowered in making those choices, and you won't feel alone because somebody else has shared their experience as well. We've covered a wide range of content, and you can find these and more on our YouTube channel as well as our Facebook pages. Various conversations, various articles, etc., as well as the website. As I said, this is part of a series, and previously we had spoken with Dr. Srinath Shirsagar and Dr. Siddhesh Kalantri on the signs, symptoms, and risks of ALL. So do check that out as well, and you will find the recordings on our social media pages. As I said, we have today Dr. Natraj KS, who's a senior consultant, hematology, hemato-oncology, and bone marrow transplantation at Sri Shankara Cancer Hospital, Bengaluru. We have Dr. Kishore Kumar, senior consultant, hematologist, hemato-oncologist, and BMT physician at MIOT Hospital, Chennai. And I'm Aparna Mittal. I'm founder of Patients Engage. Quick guidance that this session is being supported in public interest by Pfizer, and the information is meant for awareness only. It does not substitute medical advice, so please do consult your doctor for guidance on the information stated here. And the views expressed are of the speaker, and Pfizer may not endorse, and they may not always represent the platform as well. You can reach us on our social media pages, Facebook, Twitter, Instagram, YouTube, LinkedIn, or our website, www.patientsengage.com. And you can post your questions on any of the channels, and we will make sure we respond. So thank you once again, Dr. Natraj and Dr. Kishore, for joining us today and taking the time from your busy schedules. Let us start, Dr. Kishore, by starting with what is leukemia very quickly, and then we will go into the treatment options.
Very good afternoon to everybody, and thanks, Ms. Mittal, for this opportunity, and also to Pfizer. So that has been quite a broader question, just like to touch upon what has been done in the last series of these webinars for patients. Leukemia, in a very gross people's term, I should call it, it's kind of a serious blood cancer. And we have three types of blood cells: the red cells, white cells, and the platelets. And whenever anything grows above normal, we tend to call it as cancer. And this particular leukemia, we have got this type of white cells, which may be the myeloid or the lymphoid cells. When they start growing more than what is needed, the patient ends up getting these kind of cancers. And the topic for today has been acute lymphoblastic leukemia, which is a serious cancer of the lymphoid cells, the lymphocytes, which are the basic immunity providing cells for us. And the uniqueness of these cancers is it affects kind of all age groups, right from children up to elderly. So that is something in gross about leukemia, Ms. Mittal.
Thank you. Thank you. Dr. Natraj, what are the typical treatment options for acute lymphoblastic leukemia?
See, acute lymphoblastic leukemia is one of the cancers where there are a lot of landmark achievements which has happened over the last 6 to 8 decades. Once upon a time, it was just for palliation with few days and then they die. And then now it has reached a curative intent treatment where in children, 90% of them we can cure. So it's a major leap which we have taken from last so many years. And a lot of things have been learned over the time with multi-agent chemotherapies. So commonly the treatment armament that we have is conventional chemotherapy using different kinds of protocols. It may be German-based protocol. There are some Indian protocols. There are American protocols. There are Australasian protocols. And we have We have second armamentarium nowadays and recently with targeted drugs like blinatumomab or inotuzumab, many maps which have come up, epratusumab. And then we have third armamentarium, that is stem cell transplant for relapsed patients, bone marrow transplant. And now we have the newest kid in the block, which has given us a lot of hope for even for multiply relapsed refractory patients, that is chimeric antigen receptor T cells, that is CAR T cells. So these are the different treatment options which are there in the platter. And it depends on what do we use at a certain patient at a certain point in their treatment cycle. Each patient is different, and then each age group is treated differently. And each stage of the disease, like whether it is newly diagnosed, whether they have relapsed early or whether they have relapsed late, it depends on what drug we'll use or what type of treatment we'll use at each step.
Right. And I think newly diagnosed is understood, but Dr. Kishore, what does it mean when somebody refers to as relapsed or refractory or recurrent?
Dr. Natraj has very beautifully pointed out the different treatment options which are available. Generally, when the patient is presenting to us for the first time, and the uniqueness about this leukemia is the only way we diagnose, which has been already discussed in the previous webinar, is through some blood test. And unlike other cancers which can come up with some swellings here and there where the patient notices himself or herself first, leukemia, sometimes it just goes to the general physician because of some vague symptoms, and then it gets picked up through the different signs and symptoms and diagnostics. So once the diagnosis is done, this is a blood-related cancer, blood cancer for that matter. So it is there everywhere in the body. So Dr. Natraj has very clearly pointed out the 4 stages of treatment, where if you see at every stage, the treatment works at a systemic level. When I call systemic, it is not like I'm going to go and do a surgery. Whatever the type of treatment I'm going to give is going to go to the entire body and work in each and every place where the cancer has been. So we don't call it a staging here in leukemias, but we kind of try to stage it with the different other modalities. But the baseline treatment, as over the years, what we have learned through different protocols, which Dr. Natraj also very clearly mentioned, even we have our own localized Indian protocols also shooting to the needs of our local children as well as the local situations around. And we do derive a lot of protocols from our Western colleagues. So all these protocols have got a specific set of chemotherapeutic agents which go target and try to kill these cancer cells to the deepest level as possible. But when we kind of do the therapy, it is not like a 1 week or 1 day therapy. Most of these protocols will have therapies which are running for maybe a few months, more intense, and then over a period of time, a concept called as metronomic chemotherapy or maintenance is something which is quite common in acute leukemias, especially lymphoblastic leukemia. So it's a very stretched out therapy. So during the therapy, we just want to make sure in the intensive phases, we keep on doing checks. Sometimes we do bone marrows again, just to check the disease has not come back. We have achieved what we actually wanted to achieve, because these are cells. We are talking about cells which are like very minuscule, going to only a few nanometers. So naturally, it's not something which I can grossly see and say that it has come down. So it needs very specialized testing, sometimes genetic testing. We do bone marrows, we do high sensitivity flow cytometries, where we look up even 1 in a lakh or 1 in a million cells to say the leukemia has gone. But in spite of all these things, sometimes the genetic mutations are whatever the thing that is causing the leukemias are so aggressive that it is possible that some cells may be inherently developing a bit of a resistance to the initial set of drugs what is being given, and it is possible that they may start to come back again. Even the patient may be on therapy, or sometimes he or she would have completed therapy. It's not the case everywhere. 70 to 80% of times patients do carry on with their schedule and things go on well. But in an unfortunate 20 to 30% of patients, it is possible the cells may start to come back. Sometimes it overtly comes back and starts showing up in the blood, that we call it as relapsed. Sometimes when you start giving therapy for it, and if it is not giving the same results what it has given the previous time with the same kind of therapy or a different set of medications, we start calling those leukemias as refractory. That is refractory to the first line of defense or the first line of therapy what we have given to the patient. So this is what we call it as refractory. In simple terms, I should say a leukemia which has come back. But today's with the development, I should say this percentage is kind of really coming down, but still good 20 to 30%, we still face this problem of relapsed and refractory leukemias.
Right. And is the incidence of refractory and relapsed leukemias higher in adults versus children?
Yes. Should I?
Yeah, go
Nataraj?
ahead. Go ahead.
Yeah,
Yeah.
fine. Sir. Yes, to be more frank, if you just put it in a very gross perspective with acute lymphoblastic leukemia, it's common in children. But the other way around also, the percentage of people who are kind of getting completely cured, we call it as long-term remission. Sometimes we don't use the word cure, but still a long-term remission is quite high percentage in children. But being a very aggressive cancer, though it is not so common type of acute leukemia in adults, but when it comes up in adults, maybe due to reasons unknown many a times, but maybe sometimes due to the mutations which have occurred over our years of life, the standard box standard protocols which works beautifully in children sometimes may not be enough or may not be working to that extent in an adult. On a comparative basis, yes, in adults, I should say relatively the risk of relapse and refractoriness is a bit higher compared to a similar group of children, I should say.
Okay. Thank you. Thank you, Dr. Kishore. Dr. Natraj, what does it look like when somebody is in remission for ALL? Are they not on any treatment, or are they still on some form of treatment, and what is the follow-up that is needed?
See, remission, our ultimate aim in any treatment is cure. So cure, by definition, what is cure? Cure is, number one, patient should have absence of disease. And number two, patient should not be on any treatment.
Right.
Without treatment, patient should be better. So that is the definition of cure, natural definition. In acute lymphoblastic leukemia, remission may not always translate into cure. Remission means cancer is not detectable with the available methods that we have. Like, for example, if you take one table and then you see that you wipe it clean, then you can tell it, for your naked eye it is clean. But if you get a microscope, you can still see some dust, and you wipe it even cleaner. Then you use a bigger sort of a lens.
Magnifying glass or something.
See one or few things which are there. So it is in the same way, even when we assess remission in patients with lymphoblastic leukemia, we have different modalities. Like you look at the naked eye using microscope, we call it as morphological remission. And then we do test by using newer methods like flow cytometry. We call it as minimal residual disease or measurable residual disease. And we do some mutation-based or gene-based testing. Then we call it as molecular remission. One of the classical example is pH positive ALL, where BCR-ABL can be used as a monitoring. BCR-ABL is a translocation which happens in pH positive ALL. So that can be measured. So each test has got its own sensitivity. For example, if you look at the naked eyes, if one cancer cell is there in 1,000 cells, 100 to 1,000 cells, people can pick it up. If it is less than that, probably you will not be able to pick it up. By doing flow cytometry, you can bring it up to 10,000. By doing newer molecular methods, you can bring it up to 1 in 1 lakh cells. So we can call somebody as cured only if they are serially negative for about 4 or 5 years in different tests, whatever the test that you have in your armamentarium and you run it. And 4 or 5 years, they don't have any evidence of disease, then probably you can think that, yes, that patient was cured about 2 years before or 3 years before. We can't foretell and tell that based on today's report, yes, you are cured. It's not possible to tell. So majority of the times, ALL treatment anyway, on an average, depending on patient to patient, fitness to fitness, anywhere it happens between 2.5 to 3 years, treatments get completed. In that initial 6 to 8 months will be injectables, and then after that it will be majorly tablet form of treatment, except in few protocols, maybe monthly one small injections may be there. Otherwise, it's majority of the times it's tablets. So if any cancer leukemias, they don't come back in 3 to 5 years, they rarely come back.
Right.
That's the standard dictum that we use.
Right. So, Dr. Kishore, if this treatment is 2.5 to 3 years, typically, is that for newly diagnosed, or it's the same for every time it comes back? How does that translate?
Dr. Natraj was just mentioning about the different protocols. And this kind of an extended phase treatment is kind of initially done for the newly diagnosed patients. Basically, the concept was because in olden days, like as Sir was talking about the different newer technologies to detect even very minimal amount of disease in the body. Naturally, old, I mean, like maybe 2 3 decades earlier, these technologies were not available. So people were quite worried about the disease coming back again and again, in spite of the fact that a microscopic examination was looking quite normal. So they kind of divided these phases into, he very clearly pointed out, an intensive phase and a maintenance phase. Among the intensive phase, initially we use a combination of drugs so hard, hitting it hard. This is more like kind of putting a nail into a wall. So first time I'm going to hit as hard as possible. That's the best fix I'm going to get. Anytime I'm going to get it back and hit it hard, it's not going to be the same way how it is. So initially we try to use a maximum combination of drugs, though sometimes they may be looking quite toxic also, but still try to phase it in a short term so that we get a very deeper control of the disease. And once we get a deeper control, we try to make sure the disease doesn't try to come back by using some longer acting agents. We call it as the consolidation phases. And once every time, Sir just mentioned, we keep on repeating the test in multiple modalities to make sure the disease is at a desirable control, what we wanted to achieve at certain time points. So if it is maintaining in the desirable control, we put the patients to the oral maintenance treatment, which kind of runs for around overall, I should say 2.5 to 3 years in total, some cases, maybe 2 to 2.5 years in few, because many studies have seen that if at all the leukemia is very aggressive and it has to come back, the maximum relapses do happen within the first 1 or 2 or 3 years. That's the reason he very clearly pointed out. 5 years down the line, if the patient is still maintaining a disease-free period, so it is kind of taken for granted that yes, he's going to achieve a very long-term control of the disease. So we just don't want to miss that time. We have achieved a good response to the initial treatment in the first line agent, and we want to make sure the disease doesn't come back in the active period, which is the first 2 years. So naturally, during the first phase of treatment, that is newly diagnosed cases only, this kind of extended treatment goes on. And if the patient has been put on such extended treatment, it means that he or she has already achieved the desirable response, which is in one way good, I should say. And many times it's a oral based treatment. So naturally, it's not going to kind of affect the daily activities of the people. And many times children, adults, there are many people who do get back to work and other things during this maintenance phase, especially with the work from home thing going on. Even during after the induction phase itself, there are a lot of people who do continue doing that. So that's the beauty of this entire scheduling of treatment. But when it comes back, it may not be the same way. That needs more aggressive way of looking at it, actually.
Right. And Dr. Natraj, after you've been through these rounds of treatment, there are some patients who are advised, and you also talked of it as stem cell transplant, right? So is that offered in a certain kind of patient profile, or is it offered based on the first 2 lines of treatment not working anymore, for instance?
See, usually when it comes to we don't do transplant for newly diagnosed ALLs nowadays.
Right.
In very few small conditions in children, other than if somebody has got very high risk leukemia, or whether they don't respond well to initial chemotherapy based on MRD analysis, then for standard risk patients, we don't do allogenic transplants. So allogenic transplants are done in newly diagnosed leukemia, lymphoblastic leukemias for patients who don't respond well to initial chemotherapy. That is, initial 1 month of treatment is sort of a test for the patient to know how well they respond. If they respond very well, they usually do well. If they still persist with some disease with different modern techniques, then they usually relapse. So in them, usually allogenic transplant is advised, or in patients in whom some genetic workups, when we do at the baseline, we pick up some sort of high-risk genetic signatures, like, for example, somebody with the MLL gene abnormality or translocation 11 related abnormalities, then we usually suggest them to undergo allogenic transplant. In all relapsed patients, except in few select pediatric setting where very late relapses, if it happens beyond the completion of maintenance and they relapse, few of them can still be cured with chemotherapy. But otherwise, majority of the relapsed acute lymphoblastic leukemias are treated with allogenic bone marrow transplant or stem cell transplant in children. When it comes to adults, majority of them, unless they are very good risk and their response is very, very good, majority of them do undergo allogenic stem cell transplant even in newly diagnosed setting. But every relapsed adult acute lymphoblastic leukemia will, in the current standard of care, is to undergo allogenic stem cell transplant to provided they reach a very good remission with salvage chemotherapies. So usually the life cycle goes like this. If there's any relapse, we give sort of chemotherapy or some sort of treatment and put the disease down as much as possible, as minimum as possible. Our aim is to make sure that the newer modern techniques are not able to detect the disease which is there persisting, and then take them towards allogenic transplant. And usually allogenic transplant is the curative choice for the patients who relapse after initial treatment.
Right. And just to clarify, what is allogenic transplant for? Is it is it a family donor or not a family donor? What do you mean by allogenic for a layperson?
See, allogenic transplant means a transplant, the stem cells come from somebody else. So somebody else can be 3-4 different people. One is somebody else can be family member, usually siblings. And previously, I think a lot of like majority of the population used to have many children, so it was easy to find sibling donors, matching sibling donors. Nowadays, I think number of siblings are less, so finding a fully matched sibling donor is difficult. So a lot of times we end up either doing a fully matched unrelated donor transplant, which we get some stem cells from the registries. So, or we do a half-matched transplant called haploidentical transplants from parents or the sibling who is a half-match. And it's very, very rare, extremely rare for somebody to do a cord blood transplant. Usually it is sibling or half-matched family members or unrelated donor. These are the 3 places we get stem cells from.
Right. And if Dr. Kishore, how long does somebody need to wait for their transplant? Is it tough if they don't have a family donor to find half match? How good are the registries? And while they are waiting, what is being done to? I think Dr. Natraj said that you're bringing down the level of trying to get to a disease-free state. But what else is done to maintain that patient?
Yes. Basically, Dr. Natraj has talked about the option of allogenic bone marrow transplant, which is basically the stem cells from some other person, which is not our own stem cells, because leukemia is a problem with the stem cells itself, for that matter. So one way, if I want to look at it, Sir was very clear saying that India went on from 1990s itself to kind of a single or a 2-child policy. So sometimes it's kind of really difficult to get the siblings to a properly matched sibling, I should say, because the amount of match is also not like we have 4 people, it's possible that one is going to match. It is just like a rule of probability that throwing the dice and what number we are going to get. So naturally, sometimes we just have one sibling and he's a full match. Sometimes we have 4 or 5 also. It is possible that none of them are matching perfectly. But maybe till a decade ago, in these particular scenarios, because transplant is also relatively, though it's a science for the last half a century, but a lot of newer developments have started to take place in allogenic spectrum of transplants over the last 2 decades, I should say. The initial way of looking at it was to do a tissue typing. We call it as HLA typing. It is more like a signature of our cells, how we look like, and our genetic makeup, and then try to put onto the internet and looking for donors, the matching donors available across the world. This is more like the Indian movies, seeing like 2 people look alike. So the chance or probability is like 1 in a million or something. But one more thing, if you really look at it, even if you consider our own country, though we are a big country, it's more like if you really look at the genes from maybe myself and Nataraj, where we are from, and maybe somebody from the northern part of the country, we are more of an endogenous groups, I should say, genetic groups, different genetic groups. And it is very much possible that in spite of having a good number of people who are happy to donate to us, but when we really go back into this tissue typing things and trying to match out, sometimes it is very interesting that we get matches across the globe in some unknown places. Sometimes it is possible that we may be getting somebody quite near. But all these things are like, again, it's a work which unfortunately somehow the amount of what to say, the publicity that should have been done for this donation programs and donation registries was kind of in its virgin stages in our country compared to most of the Western countries. So the opt-out system was kind of followed in many countries, which made them to have a good number of registered donors. But India, though it has on a relative basis, I should say, our donor pool is not that great, but still people are kind of registries are working on it. But when we were facing these kind of problems, the other issue and the other what to say, solution that came up is, especially among the COVID times, and although there may be somebody who is ready to come and donate, but getting a hospital bed or even going to a hospital itself was the scariest thing to do for a person who is normal. They're altruistic donors. We are not going to pay them for that matter. So naturally, the numbers were starting to drop. The logistics was getting into an issue. So all this kind of made most of the Indian doctors, I should say, quite comfortable to get on with something called as a haploidentical transplant, where Dr. Natraj also pointed out that, where we started doing transplants from half-matched donors. Half-matched in the sense, to put it in simple terms, if it is young children, the father and mother are going to be half a match. And if it is going to be older adults, it's possible the siblings will be maybe half a match. Or if they have kids, their kids are going to be kind of half matched with them. So this relatively expanded the donor pool, and not only expanded the donor pool, we had the donor with us rather than getting the stem cells from a distant place. And sometimes when things are not going the right way, we were not able to get a backup of the stem cells. So this to some extent did solve the issue. But in spite of that, there are multiple other issues, I should say, because this needs an extensive talk, and the word transplant itself scares a lot of people. So it's not like in India, the patient is deciding for himself or herself. There's an entire group of family members who decide, and most of them, especially Natarajan, will be facing the same issue, the California daughter syndrome, I should say. Somebody somewhere will be from US, will be talking to us just to make sure how things are going on. So though it is easily said, especially in adult patients, making their mind up, consoling them, getting them to the transplant, it takes a bit of a time, and not to mention about the cost issues also. So till the time, I should be making sure the disease doesn't kind of come back. So I have to give something which shouldn't be making the patient go very, shouldn't be so intense that the patient kind of goes in for like a serious complications before getting onto a transplant. Because transplant, though it is done when the disease is very low, the clinical wise also, in the sense, patient should be fit enough to undergo the procedure. So earlier days, we didn't have that much of drugs. We used to give some drugs. Sometimes the disease may not be getting control. Sometimes the drug intensity was so heavy that the patients gets into serious complications with the drug itself, even before getting onto a transplant. But of late, I should thank the modern research that a lot of these newer agents, which the few maps which Dr. Natraj has mentioned, they were made our life easy relatively, that we are able to keep a decent control of the cancer this time we are waiting for a transplant, and then making the patient kind of get fit to that allogenic bone marrow transplantation. So that's what we do nowadays. We try to do these kind of newer therapies, which are not that intense on the patient, especially a patient who has already received a lot of chemotherapy in the first phase, so that we make the preparations in the back end, starting from donors, starting from logistics, cost and everything, and then we are able to get on to a bone marrow transplant. Yeah.
Thank you. Thank you, Dr. Kishore, for that explanation. Dr. Natraj, the other issue is, as you said, this typically can take anywhere between 2.5, 3 years, maybe, or at least a few months. And given the way our healthcare system is structured, people do need to travel to bigger cities for some of these treatments, etc. So what is the kind of planning they must do so that they have access to their treating team on an ongoing basis? And what do you advise your patients and their families?
See, unfortunately, majority of the leukemia treatments take too long. It takes sort of months to years. In that initial few months are going to be very, very hard for the patient and the family. Number one, because leukemia just comes like a snap. It just doesn't give time for the patients to arrange funds. And number two, the treatments which are there are expensive. So there needs to be a earning which is ongoing to support the treatment. And number three, treatments are heavily centralized. It is not decentralized.
Correct.
All these three things will put the patient to an immense trouble and family in greater worry because they don't want to give trouble to patients. So they end up taking all the stress on themselves as a family members. So majority of the times what I suggest to patients is initial 2-3 months, they will have to hang around either in the hospital or in a nearby place. There are some hospitals where people do support having sort of a caregiving homes or nearby places where they can stay. For example, some hospitals do have some tie-ups with nearby hotels. They stay there. Our hospital has got our own long-term stay center. We have our stay center where patients do come and they get treated in the hospital and they go back and stay in the place. And there's an access to the hospital via an ambulance which is provided by the hospital. So it is extremely important that they get that, number one, because the treatment for leukemia, treatment delayed is treatment denied in leukemia. There is no second word about it. And second thing is optimum delivery of treatment also is important if you want to achieve cure. The right time treatment is also very important. Right. And number three, side effects which happen because of treatment can kill the patient sometimes faster than the leukemia itself. So that side effects needs to be picked up early and treated early in right time. Common side effect is fever and infection. When we give chemotherapy, their immunity will go down, counts will go down. At that time, they don't receive antibiotic timely. Usually, we keep a gap of 1 hour. Within 30 minutes to 1 hour, they should receive the first dose of antibiotic. The more they delay, the chance of death is going to double. And then probably if somebody delays for more than 24 hours, the chance of death is more than 50 hours, more than 50%. So it is very important that they need to be near the hospital. We usually tell either in the hospital or they should be near to a healthcare facility which guarantees them 24/7 access to injectable administration. So a lot of our patients, when they come, either we tell them to stay near the hospital, or if you're staying in the home, make sure that you have an access to somebody, doctor or a nursing home or a nearby clinic, which can guaranteely give the antibiotic within 30 minutes. So we give them the letter so that they can show the letter to the doctors or somebody, and then they can administer the first dose of antibiotic, and then they can reach the hospital within 2-3 hours time frame. But this works out well for a patient who is living in the current city. But for a person who is coming away from a village or from a far off place, we have to make sure that number one, they stay, we find a place for them to stay. And number two, we also have to make sure that they get some job. So, because usually commonly what happens in our hospital for children, they both father and mother comes together.
Correct.
So father should go for job and mother should take care of the children, or vice versa. I'm not telling this way, that both ways it's possible. So we have to somewhere make a way that we find a place for parents to one of the parent to work so that they can continue their earning. And sometimes some of these workplaces can also give them access to health insurance, which can help them to provide better care. So they end up getting that. And then third thing is, it's also very important that we give them nutritious food. It is not just that they just come back and stay nearby, they eat whatever that is available. It's not like that. So we have to somewhere we have to tie up with different NGOs or possibly make a way for the needy people. May not be for everybody, for the needy people, so that we can provide them ration every month so that they can eat the right food, they can get the proteinaceous food so that they can get treated well. These are very important aspects. So we have to look towards their safe stay, good healthy nutrition, and an ability to continue ongoing earning. So these are the three important pillars in the treatment, along with central pillar is treatment, and surrounding, unless we have other three pillars, central pillar cannot stand.
Yeah, I think the awareness of nutrition actually has gained quite a lot of credibility for pediatric patients. But as you said, that we don't see that same focus for adult patients. And this I'm seeing across, a lot of the cancers, but definitely the blood-related cancers, right? So the blood cancers. So that is something that as even NGOs need to put in more effort into adult patient support as well, and even CSR. I think CSR tends to support pediatric cancers much more, but not
If a child
adult.
does not have father and mother, how the child will survive in the world?
Right. Yes. So I think it also links back to the fact that there is now evidence and people talk about higher cure rates for pediatric cancer. So I think that also makes donors
Yes.
feel that their money is quote unquote well spent, and that's
How
a
did they
huge.
reach that level? How the cure was reached? It's because of help from a lot of support groups that they could achieve that cure with the research. And in adults also, I think probably we'll reach there. May not reach 90%, but we can, with current armamentarium of treatment, we can definitely reach 60 to 70%. But it's still a very good chance for the patient. Unlike, see, a lot of other solid cancers where aim of treatment is to make sure that they live for additional 3 years or additional 2 years, where the aim is not cure. But when it comes to leukemia, fortunately, leukemias are the only cancers where you can still, even if somebody who is relapsed, you can still talk of cure, which is not going to happen in any other solid cancer. That we have to
Right,
understand.
right. Um, I
The
think
bar
that's
set is very high for leukemias.
right. And I think that's good because that gives hope, right? So we should, and hope is important as well. And you talked of the importance of nutrition. Are there any exercise recommendations that you do? And I bring this up because, again, in an Indian context, the moment somebody's unwell, we kind of make them just lie down and not do anything, etc. So we do make it a point to ask about exercise recommendations as well. Dr. Kishore?
Yeah, so that's true. You have been like quite practical in saying that. That's the sick role what we have been taught right from our young age, I should say. But that depends on two factors. One is the caregiver, which Dr. Natraj has very clearly pointed out, their understanding of the cancer, and the long-term chronic care. And there is something called caregivers fatigue also. Though in the phases there is a lot of enthusiasm, and slowly they also kind of travel together, and it really becomes tough for them, especially in times when they have to be put on isolation and with a single person around.
Correct.
We do face a lot of end up giving antidepressants to the caregivers rather than to the patient. So all those situations we do face. Exercise, one easy way what we say to our patients, let it be pediatrics. It's many a times it's quite straightforward. If the kid is unwell, the kid is unwell. It shows up on the face. So they don't have the preoccupied the procrastination kind of a thing. They don't do much. And somehow Dr. Nataraj also will accept these kids being moving with adults for a long time. The entire surrounding is not school or other kids. It's mostly the doctors, serious nurses,
Correct.
and all adults. Their IQ levels are relatively a bit higher when you compare to children of the same age. This I have continuously seen, because their understanding of life, the importance. Sometimes we both used to work in Calcutta, and sometimes in the same ward, when something goes wrong, these children do see those things, and so it's sometimes it's
So
quite.
they grow
Yeah,
up
they are more
faster.
mature. I should say they are more mature, very understanding, you will be quite fascinated to move with these kids. So that sometimes makes us so deeply attached with them, because they're long-term patients of us, and they do become like an extended family. And many times we do have children of the same age, so we kind of try to empathize more with them. Children, sometimes we find it quite easier, especially in a pediatric environment. There are a lot of engineers and
Activities,
people
right?
who can get onto some activities. Even we try to get onto some basic education stuff also, so that to keep them engaged. That's all. It's not like we are going to achieve anything out of it, but still, at least to give a deviation of mind, rather than continuously looking at chemotherapies and things like that. Adults, this has been a chronic issue because we have free fixed ideas in us, and many a times the problem one way with an internet, I should say, is everything is available, and most of the information there may be quite junk, and anybody can write anything. So when we are in a bad mood, it is possible that we keep on choosing to read a bad news or bad outcomes and start
doom scrolling, it's called.
doing that kind of a thing. So
Right.
one thing, before even starting a physical exercise, psychological counseling is needed to be done. Yes, a genuine problem. We do understand that it's something, if it happens to us, it's going to be quite tough. We don't know how we are going to deal with it, but it needs a lot of talking, though. As doctors, we can do to some extent. We do try to get some support groups, as Dr. Natraj was very clearly pointing out. Some patients who have done their therapy before them and who are kind of doing well, which can kind of break. Every individual patient is different. So though we base our findings on studies, these are done on larger groups and with some statistics, I should say. Statistics doesn't mean that it's going to go the same way how it should be, either way, bad or good. So one thing is a very clear understanding, and the other thing is to make sure from the day one of hospital stay, what we practice in our hospital is to make them behave as if they are at home, and they're going to go back home with an idea of going back home to their normal self. In a sense, not like doing extensive activities, staged activities, not in a continuous stretch, maybe 2-3 minutes of walk within the room itself for every hour. Make sure to maintain a sleep discipline, because most of the time they really do get confused about the day and night cycle, I should say. So and these drugs also, they're not easy drugs, though we can very easily say, being on the other side of the table, they just make them some bad days, some rough days, some mucositis, not able to eat properly. All these things are there, but still one thing we kind of somehow on a relative scale, what you said, I have an opportunity to treat certain patients from Africa. So somehow, sometimes there's a language barrier, though we try to make them understand. I have to do it with the presence of an interpreter, and he may not be available all the time. So sometimes I do worry whether they understood what I'm trying to say to them fully or not. But their mentality I have seen, I'm not particularly saying about a particular continent, but the more of a tribal mentality where people have been exposed to really tough situations. We have seen them just carry on with the way how they came right from day one. And many times the sick role, not playing a sick role itself, gives up a first positivity note that we don't end up in serious infections just because they are most of the time lying on bed having a hypostatic pneumonia. And being a bit motivated definitely helps, though I can't put a word or a percentage to it. But somehow our Indian patients need a push continuously, sometimes a very hard, stern voice from us also. It's not that every time you're going to be very passionate towards them, but that's for their longer good, I should say. But a staged activity, minimal activity, especially, I mean, what to say, like more broken up activity. It's not like very vigorous exercises we advise. Simple walk, 2 to 3 minutes walk every hour, sitting up and having their food, not making sure that they're lying down and kind of aspirating stuff. These are simple things. And we do have physiotherapy people also. Once that the problem with the physiotherapy is many times the platelets and other things are very low. So we don't want our physiotherapy guys to work on like how they work on with an orthopedic patient and end up bruising everywhere. True. So once their counts are all kind of back to normal, we do have a rehabilitation ward sometimes. So we get up with some therapy, but at the end of the day, it's the patient who has to understand and he has to initiate himself or herself. That initial denial phase should go, and then slowly when they see the other people getting well and going out, I think that will work for them many times. And Dr. Natraj was very clearly saying, we prefer them not to be continuously in hospital for a long time also. Some break is needed for sure. A home-like environment near the hospital. At least many times we have seen that rather than the hospital food, when they are able to manage themselves, I mean, cooking themselves according to their taste and other things, that gives a much better gut thing and a nutritious thing rather than what a hospital does in general for most of the patients. So these are all, it's a holistic care, I should say. It's not like other cancers where the patient comes in the morning, goes back as a daycare chemotherapy. It's like a long stay, and so we need to sit down, work out, and have a lot of talk again and again and again with the patient, and also make a practical solution to the caregivers also. Not like everybody is going to understand, but finances, the fatigueness, I mean, addressing their issues, talking to them separately sometimes. So all these things do matter.
Right. Thank you. Thank you so much. I know that we are over time. Dr. Natraj, final words to the patients and caregivers who are listening to this.
See, number one, leukemia is a very sort of a stressful word for anybody who hears it first. But please understand that with appropriate treatment, nowadays we can achieve cure in a lot of patients. And it is very important that the timely care is given And then it is very important that the patient reaches the appropriate healthcare system in a right time. And also equally, the treatment is going to be long. So you need to be persistent, and you need to have a way to have a sustainable treatment period. And please, third thing which I usually tell to patient is, please have same level of commitment throughout the treatment, not just in the initial 1 month or initial 2 weeks, and then you get on the treatment, you get on the commitment. And number three, whatever the treatment modalities that are there, different modalities which are there, please discuss with your doctor, and what chooses right for you at that point of time, you can consider that. And nowadays, there are a lot of newer drug options and newer treatment modalities for relapsed leukemias. In fact, once upon a time, when I was doing my MBBS or my studies, my professors used to tell, if somebody diagnosed with leukemia, they would counsel the patient, anyway, this patient is going to die, please take them home. But now it has reached a level where a patient has got leukemia, please take to a right place where you can get treated and then probably become better. And at least if they reach the right place, I think they can get cured also. And acute lymphoblastic leukemia is one of the few cancers in whole of the cancer textbook where cure is still possible even when they relapse. So the hope is not lost even if somebody is a diagnosis or a relapse. So there is still a hope and ray for treatment, ray of different chances, different opportunities for treatment. So kindly reach healthcare, get treated appropriately, and continue to have a healthy lifestyle throughout the treatment, and be prepared for a longer duration treatment. So all these things are very important, and choose a hospital which is as much as possible nearby to you rather than too far hospital.
Right. Thank you. Thank you, Dr. Natraj. Dr. Kishore, your final words.
Yeah, Dr. Natraj has really summed up everything. But I want to concur with the fact that the time when we started our medical education or whatever, so it used to be like more of we started asking patients to write up their bills and book a ticket to Kashi or Rameshwaram. But that has entirely changed now. Even I still remember when taking up this hemato-oncology as a field, people used to kind of negative, a lot of negative comments, which Dr. Natraj also would have taken during these early days, that the outcomes used to be not that great. That was a notion even among the general physicians, I should say, at one point in time. But somehow blood is a very easily accessible organ tissue, and so that itself makes it a very viable tissue for whole lot of genetic research and research oriented drugs that come up. So if you really look into the history of cancer, most of the path breaking medications or treatments have start in the hemato-oncology or blood related cancers, and then they get extrapolated to the solid organ cancers. So that way, last decade and 2 decades, we have come up a very long way. To be more frank, the further research down the line in this type of cancers is to make it fully chemotherapy free. That is, not even to get a side effect of even losing a hair during the treatment. So that's how the research is going on. So it's, as Dr. Natraj is repeatedly pointing out about cure, and which is very much possible. And somehow we hematologists, we just want to try the level best, because we have these different stages, I should say. If in a medical oncology setting, something, the cancer grows after 6 cycles and everybody loses hope and slowly things kind of wane off. But somehow, and I should thank the Indian government also for the same, because like these therapies which we have been talking right now, they are, at least I should say, in many Western countries, 100 to 200 times the cost what is being kind of deliverable to even in rest of the corporate centers in our country, I should say. That's the amount of the availability of generic drugs, cost capping on most of the essential drugs, which has been done compulsorily by the government. They all have done a very long way in kind of making this treatment quite not only affordable and reachable, and also kind of beneficial to the patients. And in lines with Make in India program, even the CAR T-cell program, which Dr. Natraj talked about as a fourth line, already our Indian research agencies like IITs and bigger cancer institutes have started coming up, and they already started producing our inherent indigenous CAR T-cells, which are just costing a fraction of what it used to cost in Western countries or even many East Asian countries. So one way, if I want to say, is not only that our own patients, it's very much possible in the near future, India is going to be a detailed destination for, already it is, but still it's going to be a bigger destination for these kind of relapsed refractory acute leukemias, where we have kind of reached what can be ideally done in any part of the world, I should say. So with that, the same words, there's nothing to lose hope. We can try, we people are there with you to try till the end to the maximum extent, and everything is possible in our country. That is the beauty of India, I should say, which was very openly we were able to encounter during COVID times when every other country was suffering. Though there may be a lot of remarks, but we had been on our own and we were proving to people that it is possible to do. So with that, I think, thank you for that.
Thank you. Thank you, Dr. Natraj and Dr. Kishore. And, to our audience, as both doctors have said, that there is hope. So don't get disheartened when you hear leukemia. Do discuss with your doctors and do not compare with treatments from, somebody that you know of 10 years ago or 20 years ago, because things have changed. So, just because somebody else did not have a good outcome a while back does not mean that there is no possibility now. So I think that's something that we do find, that while it's important to talk to other people and listen to their stories, recognize that these treatments are progressing. So what somebody else has been through could be different. Also, there is this lot of confusion around leukemia, lymphoma, chronic, acute, etc. So again, be very, very clear and discuss with your doctor, and not just talk to somebody who says that their uncle had, and so on and so forth. So I think it's important to make sure that you get the right information and make your choices in consultation with your doctors. And thank you so much once again, Dr. Natraj and Dr. Kishore, for sharing your valuable time and your expertise to our audience.
Thank you. Thank you.
Thank you.